Thank you so much for joining this ISAKOS webinar today. This webinar is presented on behalf of the ISAKOS Leg, Ankle, and Foot Committee, and the title is Approaching Achilles Ruptures in 2021. We would like to take this opportunity to sincerely thank the webinar chair and organizers. Reminder, if you have a question for the presenters, please utilize the question and answer icon. Please use the chat icon for general comments only. And with that, let's turn the webinar over to the chair.
Thank you, Michael. Good afternoon, good evening, and welcome everybody to this ISAKOS webinar series presentation entitled Approaching Achilles Ruptures in 2021. My name is Kenneth Hunt of the United States, and I'm the chairman of the ISAKOS Leg, Ankle, Foot Committee. It's truly my honor to introduce our distinguished ISAKOS webinar panelists, Dr. Nassef Mohammed Abdellatif from Egypt, Dr. Karin Silbernagel from the United States, Dr. Nicola Mafuli from the UK, and Dr. Sundar Ramasamy from India. As was mentioned, we'll be taking questions during the webinar, and we'll do our best to respond to some of those during the webinar, and we'll have a discussion period afterwards to address the remainder. We appreciate your engagement. Thank you once again for attending. With that, let's go ahead and get started. Our first presentation, I'm honored to welcome Sundar Ramasamy from India to speak to us about incidence and epidemiology of Achilles ruptures, trends through 2021. Sundar, thank you for being here. Go ahead and share your screen.
Yeah. Okay, thank you, Ken, and all the panelists and ISAKOS for having me in this wonderful webinar. And I'm going to speak about incidences and epidemiology of Achilles ruptures trends through 2021. When I went through the literatures, where I could see only very few slides, few literatures, which you could get incidence of mid-substance ruptures of the tendon of Achilles. And the few studies are from only the few regions like US, Canada, Denmark, and Sweden registry. And most of the studies are from hospital discharge registries. However, still that exact population-based incidence of Achilles tendon ruptures is still not known. The incidence ranges vary from 2 to 37 per 100,000 person. And also there is an increasing incidence over the past decade, especially in older patients because of increasing life expectancy, or could be due to increasing proportion of older adults participating in recreational and high demand sports, or could be due to comorbidity like in older patients with diabetes mellitus or hypertension that can relate to the tendon Achilles ruptures. When you take this paper, this is from the US, where they have taken from 100 hospitals from the emergency registry around 32,000 ruptures, where they can see that that increasing incidence of ruptures, especially in the middle age groups from 20 years to 60 years, which is slowly increasing from 2012 to 2016. And coming to the age and sex distribution, there's usually the first peak of increasing incidence is 25 to 40 years. And second peak is happening in more than 60 years age group. That's which we recent out in the older patients, that increasing incidence of TIA ruptures, maybe because of the overactivities and increasing participation in sports. Of course, the men are 2 to 8 times more likely to have tendon Achilles tears than the females. The less overall risk of rupture in the females could not be explained, could be a hormonal role, which was mentioned in this literature. And also the postoperative outcomes are poorer with increased risk of re-tears in females than males. And also if you see that sex distribution of TA ruptures, this is the Denmark registry where they had studied around 33,000 patients. It was published in Cases TA in 2015. The study period between 94 to 2013, where you can see that increasing incidence from 94 to 2013, almost slow increasing, especially in the age group between 50 to 70 years. But not much change in the female, but in the men, the increasing incidence of patients in the old age group. When you come to the rural and urban populations, I couldn't see much literature, but this is the literature from the Denmark registry again, where there is no difference. That means that equal participation of men and female men and women, and equal number of ruptures with statistically not significant. When it comes to the seasonal variations, again, you can see this is the paper from the same Denmark registry where the increased incidence found to be in the fall, followed by winter and spring, and lower incidence in summer. And this is another paper again that showed that the tear is increasing and highest evidence during the winter and spring, lower during summer, probably due to cold Achilles tendon prior to exercise, and sudden increase in load may predispose for tendon rupture. Or more people with a sedentary lifestyle suddenly starting doing a new sports during winter and spring can resulting in more ruptures. And also the same scenario in the Canada and the USA registries where there's more incidence of tear rupture in winter and spring and lower in summer. However, the complications of the tear ruptures in summer usually has more re-tears and complications comparing to the tear ruptures happening in winter and spring. However, the reasons are not made out in these literatures. The most common mechanism of injury is a sporting and recreational activity, which constitutes almost around 81% of mid-substance tears. When coming to the sports, I think from up to almost 60 years, the basketball is the most common sport in TR ruptures. This is a US registry, followed by tennis and running, followed by football and soccer. And then the older patients between 60 to 80 years, there because of tennis or running or hiking and stretching. When you come to the sex distribution, in the male, already I told that basketball constitutes around 46%. And the female, the volleyball followed by basketball, but they are so close. Especially this is the Sweden registry again that found that the more injuries during winter, and their scenario it is badminton and soccer and other sports could be the again the same reason which was meant out that indoor games are played the maximum during the winter season. When it comes to the operative and conservative, not many literature available to say exact evidence of operative incidents. However, this is one of the college level athletes incidents taken from the United States, around 255 patients, where they found 65% of operative rate in 20% of severe Achilles injuries. And also in that, they found that female athletes had higher operative rate compared to the male. And also the time taken to recovery comparing to the male, the female took more days, around 96 days compared to the 48 days of female patients. And also we should not forget that steady decline in surgical treatment and preference for the non-operative treatment in most of the literatures in the last decades, because all the literature what I'm quoting all from 2015 to 20, the study period is around this decade. And this is the again which I showed the Denmark registry. You can see that increase of cases over the recent years, but the decline in the surgical treatment, the more and more towards the conservative management in all the age groups. Even if you take an age group here, you can see that from the younger age group of 18 to 13 years, the treatment of surgical treatment is coming down. And even the older people, the surgical treatment is coming down. However, we should not forget that still the surgical treatment more towards an younger patients around in the second decade who takes participates in the sports activities because of the increasing strength which is shown in many biomechanical studies. There are more randomized studies. This is the Swedish data again. We can see that the injury rate is increasing from 2001 to 2012, but the surgical treatment is slowly declining. To conclude this slide with all the four registry from US, Canada, Denmark, and Sweden, these are the four which I had in these most of my talks. You see the incidence is almost increasing from 18 to 29 in the Canada and 26 to 31 per 100,000 in Denmark. And also you see the male to female ratio is from 3 to 3.5 is to 1 to up to 4 is to 1. And the mechanism of injury more often are sports related. The mean age of the rupture usually happens in the middle age. You can see around it's a fourth decade in most of the registries. And also the trend in surgical management, which I already quoted, we can see that in Canada registry, it is dropped from 20 to 9.2 for 100 ruptures. In Denmark, from 16 to 6.3, and it is in Sweden dropped from 43 to 28 per 100 ruptures. However, the limitations are, even though the results are, all these studies are similar, they do not represent the population in the whole world. The incident may not be the true, but only patients presenting to the hospital are included. However, I could not find any evidence for the degenerative tears. With this background, I thought I can just put 2 slides on the incisional tear, which happens in our hospital, which is a 600-bedded tertiary level hospital, where we do operate or treat very few mid-substance tear because we may treat few athletic patients compared to the more degenerative tear. You can see that 80% of our tears are degenerative tear, which happens usually the age between 50 to 60 years of fifth and sixth decade. We found there is a lot of degenerative tears. Of course, the male to female ratio is almost same like mid-substance tears. And mechanism of injury, the most of the injuries are resulting in these 50 years to 60 years happening because of the fall or the just sudden forceful dorsiflexion while walking in uneven surfaces. So there are more of degenerative tears. To conclude, the future research can be to evaluate the specific mechanism of the injuries beyond whether they were contact or non-contact. It may help in preventative training and improve athletic wear to avoid the future injuries. And also research can focus upon the different manifestation of the Achilles tendon rupture, including the development of chronic tendon rupture, acute tendon rupture, and chronic tendinopathy. And these were the recommendations were made by in most of the literatures. Thank you very much.
Sundar, that was outstanding. Thank you very much for that overview. Our next speaker will be Karin Silbernagel, who's going to speak to us on non-operative management and post-operative rehabilitation. Karin, thank you. Go ahead and share your screen.
Thank you, and thank you for the invitation. I almost forgot to unmute myself. So I'm going to talk about non-operative management and post-operative rehabilitation. And I'm a physical therapist, and I work at University of Delaware in the US. So if you're looking at post-injury management and rehabilitation, really at this point, they're the same irrespective of surgery or not. If you're looking at surgery or non-surgical treatment, they're both either a poor predictor for functional outcome, it's a moderate predictor of symptoms, and when we're looking at the re-ruptures rate, they're getting really close to regardless of surgical or non-surgical. When you're looking at the importance of post-injury management, though, there seems to be that the rehabilitation may be more important rather than what you kind of choose for the initial treatment. So the rehabilitation seems to be a crucial aspect of the recovery for these patients. And if you're looking at immediate management of non-surgical treated patients, that traditional ankle immobilization with non-weight bearing was not found to be superior to early weight bearing with or without functional ankle motion. So it seems that clinicians may consider early weight bearing and functional brace as a safe and cost-effective alternative to non-weight bearing with plaster casting. So looking at the non-surgical, it seems that both surgical and non-surgical have the same early mobilization. The main thing that I want to focus on too, to put in perspective when you're choosing these treatment is what are really the full obstacles to full recovery. So calf muscle weakness is one of the main thing. And we see deficits in strength of 10 to 30%. When we're looking at heel rise endurance, we see deficits of 20 to 30%. And only 50% of patients can perform a standing single leg heel rise at 3 months. And this was irrespective of surgical or non-surgical treatment. The other issue is that the tendon heal longer. So the tendon elongates during healing. And we see similar elongation regardless of surgery or not in the studies that we've done. There is a discussion about if you are aware of avoiding the tendon elongation, you could feasibly do more with it with surgery to prevent it to happen, but that has not been studied yet. And the amount of tendon elongation correlates with heel rise deficits, it correlates with the recovery of gait, and it correlates with the degree of symptoms. So this is an issue for the recovery. The other thing when we're looking at early functional mobilization is that we think tendon needs to be loaded during the healing to have improved structure. And early rehabilitation mobilization seems to result in decreased risk of re-rupture. And early rehabilitation and mobilization results in higher patient satisfaction and has not been found to affect outcome negatively in either surgically or non-surgically treated patients. So we were then asking ourselves in two systematic reviews, really, what is this early functional mobilization that everybody's talking about? And mainly it includes some kind of weight bearing, usually starting sometime between 1 and 2 weeks, followed by some kind of range of motion or maybe some isometrics. So usually the exercises are initiated at week 2. However, the exercises are very poorly described. It talks about isometric heel rise or TheraBand, but generally very poorly described. So it's hard to compare what this really means. The other issue that we're having is we're talking about weight bearing early mobilization starting around 1 week. But really, is it the same for everybody? And we tend to have these hard boots with heel lifts to minimize the dorsiflexions, to minimize the risk of re-rupture and minimize tendon elongation. And this is how we perceive people will weight bear in those. However, there are, when we see clinically, a lot of people using boots that might be really soft instead, so you might have a lot more mobility. And in some of our research now, people are buying these unicanes to do walking more and then actually have less loading. And there's also fear among re-rupture among both the patient and sometimes the physical therapist and maybe the orthopedic surgeon too, that affects, even though you tell somebody they can weight bear, how much do they actually weight bear? And that is probably something that we really need to study to understand how the loading affects the recovery. When we're looking at the rehabilitation, we divide it up into 4 phases. We call the early mobilization phase, controlled mobilization phase, is usually when they have some kind of brace or cast in that stage, usually from 0 to 6 weeks to 8 weeks. And then we start the rehabilitation, the early rehabilitation, late rehabilitation, and then the return to sports phase. And we discuss this to somewhere cover up to a year, where some people at the earliest that I've had return to sport is 4 months, the average is 6 months, and some people don't return up to 1 year. So for the controlled mobilization phase, it's usually what we're talking about, the early functional mobilization phase. And the goals in this phase should really promote tendon healing. You need to minimize the tendon elongation, but you also want to minimize the muscle atrophy. And you want to avoid re-rupture, infection, and DVTs. So the thing that we start with this is usually starting, and at the pictures in the bottom where you can see a heel rise sitting from the heel lift, usually they don't sit outside the boot, but kind of do this in the boot. So you can start actually activating the calf in the boot from the degree of plantar flexion that you have. Later stages, usually at 2 to 4 weeks, we can take them out and work on plantar flexion. It's really important here though, that you minimize the degree of dorsiflexion to avoid stretching that tendon so that you have too long of a tendon. However, you can start doing things if you're wearing the boot, like the picture down in the bottom, working on squats and weight bearing to make sure that you activate the patient beyond just considering the Achilles tendon rupture. I think it's important for these, especially athletes, that it's just the Achilles tendon rupture that's injured. There's nothing else in their body that's injured and they can't exercise. Rehabilitation during weeks 6 to 11. This is when the goal, we really want to avoid re-rupture. You have the highest rate of re-rupture once you take the boot off and people start mobilizing. Still infection and DVTs. You want to avoid further tendon elongation. What we've seen in our studies, though, the loading is we really want to increase this cross-sectional area of the tendon by the loading, so the tendons start building with putting more tissue around, kind of a callus around the rupture. We need to overcome the fear of loading. We need to recover walking and improve calf muscle strengthening. So the patients usually start walking without a brace. We have them walking with shoes to make sure that they don't walk too flat-footed. We really start strengthening the calf. If they're allowed to walk, then it's safe to perform double leg heel rises. And it's important to teach patients and therapists and others that the speed of loading affects the peak loading in the tendon. So if you're doing really fast movements, you might have higher peak, but might be a greater risk of re-rupture. These are exercises that we're performing in our clinic, like bilateral heel rises. They can cheat as much as they want, but still recruiting the healthy side and the uninjured side, seated weight bearing. And we also really work on gait training that you can see kind of working on loading that leg behind them to start activating the calf, or doing things as backwards walking again to activate the calf. to working slowly and surely in the clinic.
Walk backwards. Go.
And then we just published a study that I might share if people are interested in, but we really try to look at how do you load the tendon to understand. And we built kind of a tier system to understand how heavy these weights, the load on the tendon is. And I think the important is to understand if you're walking, we're talking about a loading index of 0.4, meaning around the peak loading is 3.3 times body weight. And from there, if you can allow walking, then you know how much you can add for other exercises. The expected outcomes at 3 months is usually we see that 50% of the patients can be able to perform a single leg heel rise. And that's what we're trying to shoot for to be able to do. We don't see any difference between surgical and non-surgical, but we do see that it's correlated with fear. So if somebody is very fearful early on, they might not be able to start with exercise or afraid of loading, and that might hamper their recovery. We do see at 3 months that people that can perform a seated heel rise with 50% of body weight, if they can perform at least 20 reps of those, then they have a great chance of performing a single leg heel rise. So working on the seated and really pushing the weight seems to be a way to really working on the standing heel rise. In the late rehabilitation phase, we're really at this point, we're less worried about ruptures. We know that the tendon elongation that's going to occur have probably stabilized at this time. So now it's mainly working on recovery of tendon strength, muscle strength, and endurance and function. And this is more of a normal rehabilitation that you consider going from progressing to jumping and running, going from jumping with 2 legs to increase the load to 1 leg. We have a milestone that we use that at this stage, if a patient can perform 5 single leg heel rises, and we're talking about 90% of their available height, because their height's going to be affected because of the tendon elongation, they can start their running progression, such as rebounding heel rises, hopping in place, and jogging in place. And these are kind of pictures of what our quick rebounding heel rises look like. That's the first step. The second step is to start then in place, working on the bilateral hopping. And then the next step is to really kind of start jogging in place. And those things you can do in the clinic prior to send somebody out to start running.
And I have a video.
When you're looking at the return to sports phase, the treatment and rehabilitation goals are return to team, return to field, to return to competition. We did publish a case study that is with Maurizio Foncini that I think describes well in a soccer player. I think the important thing here is to have realistic expectations. And in general, when you work with people that are not elite athletes, it seems to be that 1 year is the plan when they're actually returning. You also need to consider that maybe you need to think about how to compensate for the lack of the triceps surra recovery. We have, we use a test battery of various tests at calf muscle strength, endurance, jumping abilities to evaluate when we think somebody is ready for the return to sports. And we want them to be between 80 and 90% of the other side. Heel rise height measurements that you can do with a tape measure has been correlated to the degree of tendon elongation. So this might help you understand if the lack of recovery or function is related to tendon elongation that you can't rehab away, or is it due to strength deficits that you can continue rehab. So what are realistic expectations? And this is from one of our randomized clinical trials where we looked at the heel rise work, which is basically the number of repetitions lifting your body weight, the total amount of work. And we can see at 12 months between surgical and non-surgical, the recovery is between 60, 70, 78%. The interesting thing is, however, we have ranges from 35% to 120%. So there's a big variation in how people recover. And I think that's the interest, but we should continue our research, because if some people can have 120% recovery, we should be able to get more people fully recovered if we know what the problems are and how to get that better. And the same goes for heel rise height. The same goes for jumping, that we have these wide variations. One of the things that we've also done that I want to share with you is really looking at if you lose strength in the calf, can you compensate, or where do you compensate? And these circles basically show in the lighter color, the work done when you're landing and the work done when you take off. So somebody standing on one leg doing a hopping motion. And what we can see in an uninjured side, 10% of the work when landing is done in the hip, 7% at the knee, and 22% at the ankle. And then you can see you use a lot of the ankle when you push up, since this is kind of an ankle, it's like jumping rope. What we see in the ruptured patients, that the capacity to do this jumping, if you look at it overall, looks the same. But they are now significantly using more of the knee in the landing and the takeoff. And the message here is that if you're working with somebody, they might remain deficits in the ankle. Doesn't mean that they can't go back to full function, but you really should start thinking about working on the knee while early in the rehabilitation, because that's where you might have to take up some of the lack of function from the ankle. And we do see a lot of people developing knee pain and things. So we're really working early on knee strength to make sure that we can help them with the compensation. So when we look at the rehabilitation, some patients recover 100%. So it is possible. The rehabilitation mobilization is crucial for outcome. Historically, we pushed the boundaries of rehabilitation in the surgical group first, but up to this point, we have the same early loading has been equally successful in non-surgical patients in the next step. I think at this point, we're probably not going to push it more, but we need to understand what is it that makes somebody successful and somebody not. But the main difficulties are from the rehabilitation perspective is that to measure how much the exercise actually load the Achilles tendon is something that we try to figure out to understand how the exercise works. We need to exercise the muscle and we need to understand the load on the tendon to both protect the tendon and give it enough load to actually recover. And we also need to understand what muscles are activated during the exercise, because somebody can plantar flex their foot in the exercise, but use mainly flexor hallucis longus and not then really working on the calf that we're planning on. So with that, I want to just acknowledge my funding sources and thank you for having me.
Karen, that was outstanding. Thank you for going through all of that. Incredible update. A quick question from the chat, just because it's timely. Is there any role for non-operative management of a distal rupture and avulsion rupture from the calcaneus, or is this only for the mid-substance rupture?
I would say that these are all studies made for the mid-substance, and you have to realize that, and that is where you can get the tendon ends together. I think all of you from the surgeon's perspective and things too, I would be much more concerned to assume that somebody would heal together if it's in a distal rupture, especially if it's closer to the bone. So, but I think the research is not there to be 100% supportive of that. So
perfect. Yeah, that was my understanding as well. I appreciate your succinct answer. So we'll move on to the next presentation. Dr. Nassef Abdellatif from Egypt is going to speak to us about his unique approach to repairing Achilles and briefly his journey in getting there. So Nassef, thank you.
Thank you, Ken. Everyone can hear me properly?
Yeah, it sounds great.
All right. Okay, so I want to thank you, Sakis, and thank you especially, Ken, for putting this together. I'm already learning a lot, and I want to thank the excellent panelists with me. So as Ken alluded to, I'm Nassef Mohammed Nassef from Cairo, Egypt, and I'm going to basically be talking about everything other surgical options other than the percutaneous in 8 minutes. So that's quite a task, and I hope I do not dad along there. So these are my disclosures. They do not have any relevance in particular to this particular talk. Now, I think the aim here is to try and give a broad overview of the rationale behind the surgical repairs for the management of these acute Achilles tendon ruptures and show some of the recent evidence in the literature regarding these surgical procedures. And I might be able to detail our recent arthroscopic surgical management specifically for these acute Achilles tendon ruptures. Now, starting off, what have we learned from functional therapy? And obviously, I prepared this talk before I heard to Dr. Silvernagle. But I think what we have learned from functional therapy, or even traditional therapy, is that the Achilles tendon just wants to heal. Now, early functional motion they might reduce the re-rupture rates. But as each of the previous panelists alluded to, you do not want to lose that musculotendinous tension. So you do not want to end with a good Achilles repair, but you still have lost the musculotendinous tension. And if you're doing it surgically, you want to minimally disrupt the paratenum and the soft tissues in that motion, in that area. And we have learned from biomechanical and experimental studies that early motion would allow for the proper collagen formation. Now, but what exactly is functional therapy? Like Dr. Sebenakel has shown us a perfect example of, and she used the same paper actually. This was a systematic review from 2019, but you know, we still do not have a standardized definition of what exactly to do. Day 1, day 2, the second week, the fourth week, and we're still have the variable interventions in the outcome measures. Each and every paper would differently approach this, and the outcomes are not exactly the same. And what have we learned, on the other hand, from open repair surgery? Well, we've learned that less is definitely more. So that is in regard to the sutures and the amount of dissection you do. And as we said, the skin is very, very fragile and it can break down easily. And this is the nightmare for anyone who's done any one of these open. And we've been repairing these surgically ever since Hippocrates, and more recently since Parr in 1633. Now, this was when the first person that was attributed in modern literature to start treating these surgically. And we've seen different sutures, suture configurations, whether it's a direct repair, whether it's an augmented repair. We've seen double bundles, single bundles, double Kesslers, single Kesslers, Karakovs, and even 4-strand Karakovs. But I really don't believe it's the amount of tissue, the amount of, sutures you put in. And they all have one thing in common. I'm not here to actually discuss the surgical techniques. As you can see, they're varied. But I think what usually happens with these open repairs is what we're afraid of is the skin breakdown, and where they are most fragile biomechanically, we know it's at the suture knot end, which is usually in between the ruptured tendons. And this is where I think Sam Labib, as we know, he invented this, or he told us about this gift box technique. And he's also incidentally of Egyptian origin. And his technique showed us that you could also take these knots and place them as far away from the ruptured sites as you can. And that would possibly reduce the amount of failure that will occur at that knot suture interface. So what is the evidence? And as we've seen, it's been fluctuating in the last 2 decades. We have had randomized control studies that have started persuading us to go to surgical, to non-surgical and operative techniques. But like the previous panelists showed us, these are studies that were usually done between 2000 and 2004. And also in meta-analysis, we've seen that people are saying that there is no sufficient evidence to persuade us that operations might lead to better functional recovery. And Soren Sauer's, of course, paper was also one of those that was defining, and it said that it's best for us to use conservative treatment that should be considered if you do have the means of functional rehabilitation. And actually, some countries and some regions, like Dr. Sanchjan showed us, they have actually started swaying away from operative treatment or surgical treatment altogether. And if you look at their registries, as the doctor showed, you would find them decreasing in their surgical rates. This was a very recent one that came out in the foot and ankle surgery. It was from our sister university in Cairo, Ain Shams, and they showed the surgical versus non-surgical in a systematic review and meta-analysis. And they decided that from the literature, the surgical techniques might reduce the rates of re-ruptures, but they also have a higher incidence of complications. So the pendulum is still swaying. We're being taken non-operative, we're being taken back to the surgical, and then maybe back again to non-operative. And I think we're still not yet decided. But some things have been, well, not done and dusted, but they have been shown. Augmentation, it probably doesn't add much to a direct repair. And also, as Dr. Sebenakel showed, whether you're doing operative or non-operative, early motion is one of the most important things to allow that tendon to heal. And also, tightness of the repair and age, and this was a very recent study by Carmart and colleagues just in 2020 that showed that the tightness will be a predictor of that heel rise height and will show you how good you're actually going to be getting that tendon to heal properly. and also out of the Foot and Ankle International in 2019, it showed that the post-operative Achilles tendon elongation, if you measure it with the Achilles tendon resting ankle, if there is an elongation, it will have a deleterious effect on the plantar flexion power. And we still do not have a general consensus about the method of actually measuring these tendons after we repair them or treat them non-operatively. The most recent systematic review, also in 2020, it showed us that possibly the minimally invasive are better than the open. An active functional rehabilitation is possibly better than a traditional functional rehabilitation, standard rehabilitation. So if you're going to go, you'd either choose the minimally invasive or the active functional rehabilitation. But what about professionals, players? What about the high elite athletes? Trofa has done a lot of work in this subsegment, in this specific segment of people, and it's shown that you'll be surprised to learn that maybe return to play, 30% of these patients will not possibly make it. And they might still be dwindling around their pre-injury level up to 2 years. If they do pass the 2-year level, they might get back to their pre-injury levels again. So people have been swaying us, if you're going surgical, you might go to the mini open. But what exactly is mini open? There's this gray area in literature where, is it the smaller incision? Is it that you have to visualize the tendon ends? Do you have to place the sutures directly into the Achilles and repair the part end, or do you take them through the skin? And these is being more commonly referred to as the percutaneous, and I'll leave that, of course, to our chairman, Ken, to talk about. But there are people who have described these small, minimally invasive techniques to repair the Achilles tendon, and they show you that they can reduce the skin incision. So in that minimally invasive era, there is the arthroscopy, of course, and we like the arthroscopy. It's nice, it's niche. But what they were doing in the very relatively few studies was that they would be putting the scope in, looking at the suture ends, and making sure that their percutaneous technique would come out through the suture, through the ruptured ends of the Achilles. And they might even use sonography with that. And this is where we thought about, me and my group, Jorge Batista and Helder Pereira, we decided to do the endoscopic flexor hallucis longus transfer for the acute Achilles rupture. We do know that it has been working for the chronic cases, and we decided to try them out in the acute. And our idea behind that was we wanted to attain the adequate musculotendinous tension. We wanted to provide a biological environment for healing, provide the adequate rapid functional rehabilitation without that fear factor, and to minimize the skin and soft tissue for the open and the sural nerve complications for the percutaneous. And when we look back in literature, we saw that there was a huge amount of literature, and they were all assessing them by the AFAS, the ATRS, perhaps, and the TEGNA. We used all of these and the return to play, but we also, of course, measured the hallux dynamometry and the ankle plantar flexion strength. And what was very important in our studies, we looked at the Achilles tendon resting angle, and we would do that both preoperatively at the injury. Intraoperatively, as you can see, we would drape both legs and both feet and check the Achilles tendon resting angle. And then at the end of the operation, we would try and mimic as much as possible the normal resting tension of the normal contralateral side. And it was surprising to us that when we looked at these at a minimum of 18 months, we found that the FHL dynamometry, the ankle plantar flexion, the ATRAs were more or less insignificantly between the operated and the non-operated side. So it's just a quick illustration. I'm not really running up off my 8 minutes. This is just the a case. Now this is 1 week, and we would do the 1 week post-operative just to check that we have placed the screw exactly where we want it, as far back posterior. We've taken that FHL tendon back to where we want it to be. And this is the 18-month post-operative in one of our cases, showing you how much the tendon had hypertrophied. And there's a homogeneous streak of black there with the Achilles. It's healed nicely enough. And so that would be the pre-op, that would be the post-op, and that would be the 18-month post-op. Now, if I were to show you an Egyptian soccer player, you'd probably say, yeah, well, he's Egyptian, so he probably doesn't play very good football. But if I show you one of Jorge Batista's Boca Juniors players, Argentinian soccer player, well, maybe that would have a little bit ring. And you can see this is the guy here on the right, and you can see that explosive burst of spurt. He had an endoscopic FHL repair done, I think it was a year and a half before this, and he returned back to play. So in conclusion, the Achilles tendon will try to heal. You must try and recreate your musculotendinous tension. You should try and disrupt the paratendon and the soft tissue as minimally as you can. Early motion will probably allow for proper collagen formation and probably reduce your re-rupture rates. Minimally invasive procedures might provide adequate comparable results if these same principles are met, albeit with probably a lower complication rate. But we should be very critical of literature because, as you can see, we still need high quality studies in various areas. We're in 2020, 21, and we're still not quite there. And we should have standardized methods of evaluation. Thank you, and I hope I did not really shoot my time much.
Oh, Nassef, that was terrific. Thank you very much. That was a great overview and very interesting to see your path toward that technique. And I'm looking forward to seeing more of that as you move forward. Can you see my slides okay? Okay.
Yes, great.
Yes, great.
So I'm going to just speak briefly on a cutaneous repair technique. I have no relevant disclosures to this presentation. So Achilles tendon ruptures, as we've discussed, are very common. We see them frequently in athletes. Open repair is still the standard, I think, for most elite athletes. Now, traditionally, the larger incision open repair was associated with higher complication rates, long time to recovery, and really an unpredictable return. So for all the reasons mentioned, we tried to identify less invasive techniques and better functional rehab techniques in order to address that. So I'm going to discuss a percutaneous repair technique that has been developed. So I'm always evaluating these patients. It's very important to identify where the rupture is for this technique because you want to be very close to the rupture when you place your incision. It's also important to mark out the sural nerve, as you see there with those dotted lines, and protect that throughout the case. That's definitely the most concerning structure for injury. Once you've identified the rupture site, I make the incision at the proximal end of the rupture. I separate out the peritoneum. That's a very important layer to close independently, but all the work is done deep to it. Now, the jig I use is commercially available. It essentially goes deep to the peritoneum on either side of the tendon, and you can dial it in to distract so that you can get the jig on either side of the tendon. And then you're able to place sutures using a Beath needle through this. So you know that you're on either side of the tendon, you know that you're not injuring the sural nerve, and so you can advance your sutures and get a good bite on the tendon distally and proximally. Now this system advances 5 sutures, 3 of them are a suture tape material, which is a little bit stronger in pull-out strength. And then the central of those sutures is knotted so that there's no sliding at all. And that just prevents risk of elongation during rehabilitation. So once the sutures are placed, you can advance them into the central incision. As I mentioned, excuse me. As I mentioned, there is a loop suture in the middle, so you can actually lock the center stitch so that there's no sliding and so that it won't pull through the tissues. And that's really helpful to give you the stability and the repair to allow early rehabilitation and early range of motion. On the proximal end, it's the exact same process. So you advance the 5 sutures, you lock the center one, and then all the sutures will be out in the middle for your repair. So there are alternatives to this. If you don't have access to one of those jigs, there is a cost to it, at least in the United States. There's good reports that a ring forceps, which is essentially the same concept, it's a little more technically challenging, but it's the same idea. And that's shown to be a very effective way to do a percutaneous repair. I always repair these essentially in maximum plantar flexion. As Dr. Silbernagel pointed out, we don't want these tendons to elongate because that's a really hard thing for us to it's something we can't actually rehabilitate or reverse. So I keep the ankle plantar flexed. I tie each of those 3 strands together. I will oversew the repair centrally with an absorbable stitch. And then really important, as you see, to protect the sural nerve throughout the repair. That's one structure you just don't want to injure or stretch. I'll always repair the peritoneum as a separate structure. That's the blood supply for the tendon, and you don't want it to scar into the skin because that can create symptoms as well. You want to check your tension, make sure it's intact, and make sure you like where it is before you close up because you can always change it at that point. And then I'll routinely use biologics. So I like platelet-rich plasma. I mostly will use this when there's some evidence of degeneration of the tendon on the MRI examination. But it's a nice tool. It reduces inflammation and has some good evidence behind it. The closure, as you can see, is really low tension because of that transverse incision along the skin lines. There's very little tension, and so the incision heals quite rapidly, and I splint it in plantar flexion for 10 days before starting rehabilitation. Important to note that the surgical times are much shorter with the percutaneous repair, at least in my hands, than the previous open repair. There's good data to support this. Bob Anderson's group in Charlotte in the US published a relatively large comparative study. They showed no differences in re-ruptures, nerve injury, or wound complications, but they did find that the percutaneous approach was more likely to return to activities by the 5-month period. I want to point out that the percutaneous approach has coincided with acceleration and rehabilitation techniques, and I think that's a big part of why we're getting patients back sooner. A recent meta-analysis of studies up until that date show that there is some benefit to the minimally invasive technique, the percutaneous technique, in terms of outcomes, infection rate, and return to pre-injury level of activity. So there's good data to support this. PRP briefly, this is obviously a big topic. There is some evidence, not strong or consistent, but there's some evidence that this can be helpful. One study showed that the MRI maturation index was better in the PRP group than the non-PRP group. To me, this is an easy, low-risk addition that I believe is helpful, and I think athletes believe it's helpful. So return to sport, Dr. Silvernagle covered this well. This is really, really important for all providers to be involved in this process. I use an early weight-bearing and functional rehabilitation protocol. Historically, return to sport, we've done a pretty good job, but not great. You can see that about 30% of professional athletes don't return to sport. Most of this is using previous surgical and rehabilitation techniques. And so we're hopeful that minimally invasive techniques and others, as have been presented today, can improve this, both how quickly we get patients back to sport and how predictable the return can be. So in summary, the percutaneous repair has upside. It's a shorter surgery time, it lowers complication rates, is associated with early return to activities. It's not technically difficult, but we do need more data to demonstrate that this has return to sport advantages in order to justify the learning curve and the potential cost. So with that, I will unshare my screen, I think, and we will move on to the last presentation. My honor to welcome Dr. Nicola Mafuli. Dr. Mafuli will give our final presentation on his novel and cost-effective technique for Achilles repair. Nicola, thank you.
Thank you very much. I'm sure you will all agree that the presentations have been absolutely superb, and therefore there had to be a way of lowering the standard, and that is why I've been invited to talk at this in this great webinar that Dr. Hunt has organized. Let me go through some of the concepts behind management of Achilles tendon rupture. What we want to do when we face a patient with an Achilles tendon rupture is to minimize the morbidity of the injury itself. It has become very evident over the course of the last few years that we want to reduce the post-operative tendon lengthening. We want to optimize rapid return to full function, and we want to minimize other complications. Classically, surgical management has been performed either through open or percutaneous or minimally invasive techniques. And recently, more and more evidence has been accumulating for percutaneous techniques. And Dr. Hunt has put forward some of the techniques that are jig-based and are very, very accessible to just about everybody. Up to now, open surgical repair has been considered the gold standard for Achilles tendon ruptures in young and fit individuals. This is one of my old cases. The last time I've opened an Achilles tendon for acute surgery was about 20 years ago. And this what it really looks like. There is it's a real mess. I'm really pretty sure you will agree with me. But in general, advances in surgical techniques encourage direct tendon repair, and the excellent results of surgical repair indeed have helped our athletes to return to their pre-injury physical activities, even though it must be said that if you are an elite athlete and therefore you will be in the top fifth centile, sort of top 5% of the population working at a very high level of physical activities, then we don't quite do as well as we would like to do. And that is, as it has been shown, about 30% of our patients at that kind of level will not be able to return to full normality. We've spoken about primary augmentation, and the scientific evidence does show that there are more complications and there are no advantages over simple end-to-end repair. And in my hands, it has been totally banned. I happen to have been the head of the department for several years now in my own setting, and nobody dares doing a primary augmentation repair using anything, because they know they would be crucified the following day. We've spoken about percutaneous minimal invasive suture technique. These are the common ones that have been described over the course of the last 40 years or so. The classical one has been the Mayan Griffith technique over here in 1977. Remember, Mayan Griffiths were based in Honolulu. It's a beach society, and therefore they had to have small incisions because people would be showing off their legs and didn't like the big ugly incisions that were produced by open repairs. Webber Bannister in Bristol described some very elegant percutaneous techniques based on 3 transverse incisions along Langier lines, one distal, one at the rupture side, and one proximal to it. Mike Carman was my registrar when we described our own technique. Mike was the first author for the technique that had been used since 2001. And in those years, also Mathieu Assal, who is in Geneva, described the Achilles technique, which has been the mother of some of the percutaneous technique which you have seen earlier on presented by Dr. Hunt. This is the Carmone Fully technique. It is undertaken under local anesthetic, and you can see it's based on a total of seven small incisions. The largest one is the transverse incision in the area of the rupture itself, and it's about 1.2 centimeters. All the others are produced with an 11 blade, which is the same kind of blade, the same kind of scalpel blade that I use when I do arthroscopy. So they are in the region of 0.8 to 1 centimeter. Up to now, the meta-analysis and the systematic reviews have shown that when comparing Achilles tendon-percutaneous repairs to traditional open procedures, there are lower complications rate, and the results are essentially the same. I've used percutaneous techniques in the elderly patients, in diabetic patients, and even in high-performance athletes. The acute, the Mayan Griffith repair is the grandmother, essentially, of all the percutaneous repairs. And even though it's very elegant and it has changed our understanding of these repairs, it does have a high rate of iatrogenic cerebral nerve injuries. And if you look at with a critical eye at the available articles, you will see that up to 30% of patients may experience a cerebral nerve injury. Webb and Bannister developed their own technique in 1999, and we modified the method using stronger absorbable suture. And instead of using a simple box configuration, we used Kessler suture configuration. But things have changed, and now we use the technique that I was telling you about with a total of 7 stab wounds. These are the sequences. I'm sorry, I didn't incorporate a video over here, but if you go on to View Medi, you will see a video performed in real time of me performing the technique, and it takes about 7 minutes to perform. It is cheap, it allows strong repair. As I told you, it can be undertaken in older patients and in elite athletes, and it has similar outcomes whether it's performed in younger or in older individuals. There is no doubt a reduced risk for cerebral nerve damage because the stab wounds are parallel to the course of the nerve, and in this way we prevent such injury. Also, we perform this technique under local anesthesia by infiltration, by local injection of local anesthesia. And so if we transfix the sural nerve, which may happen at times, then it is easy, the patient will tell you, and so it is easy to remove all the sutures and start again. There are advantages in Achilles tendon repair using open repairs. Despite the high risk of skin wound problems, if you believe in correct alignment of the torn tendons, then obviously by observing what you are doing, you are able to align the tendon ends perfectly well. The functional results are good, but they are good also in percutaneous repair. There is a less chance of rupture, but the recent meta-analysis comparing open repair with modern percutaneous technique shows that there is really no evidence of a difference. Some surgeons still think that open repair offer superior strength of repair, but please go and read the 1990 article in Foot and Ankle International, which describes the biomechanical studies which compared open versus percutaneous techniques. And you will discover that the open technique used double the number of strands used in a percutaneous technique. And therefore, it is not surprising that it was doubly as strong. Both techniques allow early mobilization, early active mobilization, so it is not really an issue that way. In our technique, the way in which we construct the repair allows the torn tendon ends to be advanced distally in a symmetrical fashion. We can pull simultaneously both medial and lateral sutures, and we approximate the torn suture end until the defect is no longer palpable. And that transverse incision, that 1.2 centimeter transverse incision, allows us to see directly what is happening there. We maintain maximum plantar flexion, as Dr. Hunt does, because the most important thing in our hands is to avoid subsequent tendon elongation, and we do that way. What we have shown in several papers has been that surgical repair using percutaneous technique is better in our hands, is better than conservative management, and the superior cosmetic appearance is accompanied by also better functional results. Minimally invasive surgery offers similar results to open surgery with decreased perioperative morbidity. It can be performed as an office procedure, therefore the patients don't need a bed essentially. They can stay just a few hours in the hospital. This minimizes costs for themselves and for the hospital itself. In conclusion, there is an increased incidence in Achilles tendon ruptures, as the first speaker has shown. The evidence for best management is still debated. Open surgery in some hands still stays as the gold standard, but it has a high risk of surgical skin breakdown, quantifiable in about 11%, and the wound problems are prevented by percutaneous repair. We perform a percutaneous repair under local anesthesia, followed by early functional rehabilitation. This is increasingly commonly performed in our setting, and we consider in selected patients, but I use it in elite athletes as well. Some of you wanted to know, was part of the chat that I picked on earlier, whether we can perform these techniques in cases of delayed presentations. This has been recently published in the American Journal of Sports Medicine, and we have shown in a case control study that delayed presentation up to 30 days still allows a safe percutaneous repair. I must say that this is not a novel result. And for example, the work by Professor Thurman in Germany does show that already in the 90s, they knew that this was the case. In conclusion, therefore, several percutaneous techniques are proposed. There's a lack of appropriate trials. There's no trial that compares head-to-head two percutaneous techniques. And in that respect, we need more controlled trials. There is no clear consensus regarding optimal postoperative rehabilitation protocol. We do like immediate weight-bearing exercises and early range of motion exercises. It looks as if all of us would agree that we should avoid dorsiflexion and that we should avoid stretching. massage is controversial, but I don't like my patients to be massaged in any ways, because if they undergo massage, I've seen several cases of reactive inflammatory reaction, which are then very difficult to settle. Remember, please, the recovery is less good than we thought. In conclusion, there is no clear consensus, however, but early range of motion exercise when the early weight bearing is advocated. And our editorials in the BMJ and in the Lancet do show how treatment decisions should be taken early, and that whatever we do, please make sure that you mobilize these patients early, and that you weight bear these patients earlier. Thank you.
Thank you, Nicola. That was outstanding and a really, really cool technique. So to all of the attendees, thank you for attending. You're going to see in front of you a survey. There are 3 questions on this. We'd like to get an idea of current practices. So if you have a moment, both attendees and panelists, to just fill out this 3-question survey that's on your screen, that would be really helpful. So some of us, the panelists, are going to stick around to answer some of the chat questions. Unfortunately, this brings us to the end of our live time. So I just want to give a special thanks to the ISAKOS team for putting this together, and a thanks to my panelists. That was really an outstanding set of talks. Thank you so much for taking the time and for enlightening all of this. I learned a lot, and I greatly appreciate it. And finally, to the attendees, thanks for being on and for your attention, and have a wonderful rest of the evening. Take care, everybody.
Thank you. Great pleasure to have been here. Stay safe.
Yeah, I'll reiterate that. Stay safe, stay healthy, and keep yourselves well.
Thank you so much to the webinar chair, faculty, and attendees. ISAKOS will host the recorded webinar with the presentations on the ISAKOS Global Link site, and webinar attendance certificates will be provided to registered attendees via email. ISAKOS is offering a special membership offer to all non-members. Use promo code NEW2021 to become a 2021 ISAKOS member for only $199 US, a savings of more than $75. This offer is only valid through March 31st, 2021. Please save the date for the ISAKOS Congress, November 27th through December 1st, 2021 in Cape Town, South Africa. Don't miss our other upcoming ISAKOS webinars, including one titled Bony Defect and Shoulder Instability, Open and Arthroscopic Solutions, set for Wednesday, February 24th, 2021 at 2000 UTC. ISAKOS webinars are supported in part by an educational grant from our contributing sponsor, Smith & Nephew. Thank you so much, and have a great day.